And we were talking about non-small cell lung cancer being a complex space, and the treatment paradigm has changed rapidly. We'll focus on stage 4 non-small cell lung cancer here, where we're focusing on targeted therapies, chemotherapy, and immunotherapy as the treatment paradigm of choice. So going back, 5 to 10 years ago, first-line therapy for all patients with metastatic lung cancer was, chemotherapy alone. Fast forward to 2023, we have multiple approved targeted therapies as well as immunotherapy. So how do we select the best treatment for our patients? Is that, as we heard earlier, there are multiple different driver alterations. So truly a molecular revolution with many approved therapies. We're going to focus in on KRAS. So KRAS makes up about 30% of all patients who have lung adenocarcinoma. And KRAS mutations more commonly occur in Caucasian patients and those patients who have a former history of smoking. And when you look at the KRAS mutation population, of the KRAS mutant patients, KRAS G12C is by far the most common mutation, makes up about 42% of all KRAS alterations. So if you could do the math, and we'll do it together, 12% of all patients with non-small cell lung cancer diagnosed here in the US have a KRAS alteration or a KRAS G12C alteration driving their cancer. What's interesting to note here is if you go East Asia and China, for example, only 3 to 4% of patients will have a KRAS G12C. So these are really different populations with different prevalence of this mutation. So what is KRAS and what does KRAS do in the cell? So KRAS is really a molecular switch. And when it's turned on, the protein turned on, you can get constant signaling through that pathway, telling the cell to grow. When that switch is turned off, you don't get signaling through that pathway. And this is a critical pathway for cells in order for growth and proliferation and differentiation. And this is a really nuanced system where you have an on and an off state. You can imagine that thermostat in your house. And the way that that's mediated is by something called the GTP and GDP bound state. What happens in mutation or cancer is that the KRAS switch is always turned on. So KRAS mutations lead to this constitutive activation where you get constant signaling through this pathway, leading to proliferation and metastases. So how do we identify these alterations in our clinical practice? So lots of molecular testing is done in order to try to identify different alterations. So historically, we were using, immunohistochemistry and FISH, and these are really more outdated tests in order to do these types of testings. And what we really need is broad panel next generation sequencing. And Dr. Prushigal mentioned earlier, these are tests that will not only identify KRAS, but can identify all alterations using a limited amount of tissue. So really important when you're seeing your clinician, I want you to ask, or family members, ask if I'm having broad panel next generation sequencing. Some of the more outdated tests, such as FISH and IHC, do not have the ability to detect the KRAS alterations. There are some PCR-based assays that can do this, but really next-generation sequencing or broad panel next-generation sequencing is critical here. Here you can see a patient of mine with broad panel next-generation sequencing was identified to have a KRAS G12C alteration. And as we all look at these reports, we know they're complex, and there are other alterations that can co-occur. And we'll talk about some of those, such as STK11 and KEAP1 as well. So not only asking for the next generation sequencing testing, but then going over that report with your oncologist and asking them, what does all this information mean? I think it's critical to help guide your care. So we know that patients who have a KRAS mutation generally have a history of smoking and generally have many mutations in their cancer. Unlike patients who have EGFR mutations who may have never smoked, who don't have many mutations in their cancer and may not benefit from immunotherapy, patients with KRAS alterations do tend to benefit overall to immunotherapy. What we're looking at here is a very important study. It's a group of patients who had KRAS mutations compared to a group of patients who did not have KRAS mutations. So in blue, you see those patients who are KRAS wild type. So normal KRAS, no mutation. And you see that they survived at an equal rate to those patients who had KRAS mutations in red there. So telling us that patients with KRAS alterations may respond well to immunotherapy overall. However, we know that the story is a little bit deeper than that, right? We know that KRAS mutations are not all the same. You have different alleles. So we obviously have been talking about KRAS G12C, but patients can have KRAS G12D or G12V. And it's important to note what KRAS mutation you have. And then even within KRAS G12C, patients can have other co-mutations. And the other co-mutations are sort of like the genetic history of the cancer, what other mutations have accumulated and occurred over time. So some of the more common mutations that we see are STK11 and KEAP1. And I'll show you some data showing that patients who have more complex tumors or more heterogeneous tumors may not respond as well to immunotherapy alone. And we may need to think about this patient population somewhat different. So this is data that's somewhat old now, about 7-8 years, generated from MD Anderson, looking at a subset of patients who had KRAS mutations. But the team went a step further, not only looking at the surface alteration, but what other alterations did these patients have? And you can see that they defined 3 separate groups here. I want to focus in on this KL group on your left-hand side. The KL group are the patients who have a KRAS mutation, as well as STK11 and LKB1. And we know that, historically, these are enormously cold tumors, right? Tumors that are generally not responsive to immunotherapy. So when we look at the PD-L1 expression or programmed death ligand 1 expression is a marker on the surface of cancer cells that helps predict how likely immunotherapy will work. So when you look at the expression of PD-L1 in patients who have STK11 or LKB1, which is the protein, these patients tend to have very low expression levels of PD-1, which then correlate with potentially poor responses to immunotherapy. Now, why is the response to immunotherapy so poor in this patient population? We know that STK11 alterations suppress the tumor microenvironment, and really nicely shown in both a retrospective series and then in a prospective study looked at retrospectively. Dr. Scalidi's group here on the right-hand side were able to understand the response rates in patients who had this STK11 mutation versus those who didn't. So in red, if you see that in panel A, in red, the KL, those are patients who have KRAS mutations as well as STK11. The response rate, how common their tumor shrunk, was only about 10%. So that's pretty low. Whereas you look at the green, which is KRAS only, so those patients did not have any other KRAS alterations, K only, the response rates are in that 35-40% range. KP is a group of patients who had KRAS and P53, which interestingly respond very similarly to immunotherapy in those patients with KRAS alone. And when we looked at this also in a large prospective trial, Checkmate 057, very similar in those patients with KRAS alterations and STK11, the response rate was very low, sub 10%. And in those who had KRAS and P53 or KRAS alone, the response rates were far better. So not only is the response to immunotherapy worse in this patient population, we also know that the response rates are worse to chemotherapy. So this may be a poor prognostic sign as opposed to a predictive factor. Now, jumping into some of the KRAS therapeutics that we have available, it's really been a long road, and KRAS has been thought to be undruggable for many years. Here you can see the sort of discovery of the KRAS mutation back in 1967 and many negative trials. I have colleagues that have been involved in 30, 40 negative trials in this setting. Really wasn't until 2013, and I'll show you the really novel biology of how we are now able to target this alteration. More recently, in early 2021, we saw the approval of sotorasib, the first KRAS G12C inhibitor, and more recently, adagrasib, the second FDA-approved KRAS G12C inhibitor.